Welcome to this presentation on how to formulate antibiotic policy. Today, we will explore the critical integration of microbiology data, institutional policy, and clinical bundles to defeat antimicrobial resistance, AMR, and healthcare-associated infections, HAIs. AMR is a dual-threat landscape. At a macro level, resistance cycles between agriculture, human hosts, and inpatient care facilities. At the micro level, the cost of delay is staggering. In cases of septic shock, every 1-hour delay in effective antibiotics over the first 6 hours decreases survival by 7.6%. Remember, inappropriate initial therapy is just as deadly as delayed therapy. True stewardship requires institutional backing. Governance is centered in the Hospital Infection Control Committee, HICC, led by the medical superintendent and the head of microbiology. Supporting this is the AMS core team, the engine of the program, comprising ID physicians, ID-trained pharmacists, clinical microbiologists, and hospital administrators who provide the data and feedback necessary for success. The primary objective of AMS is to optimize clinical outcomes and reduce adverse events, not merely to cut costs. This is achieved through 8 pillars: increasing guideline adherence, educating healthcare workers, limiting resistance, decreasing adverse events, reducing healthcare costs, decreasing C. difficile infections, reducing inappropriate antibiotic use, and ultimately improving patient outcomes. Following CLABSI M39A4 standards, we transform raw patient samples into a ward-specific cumulative antibiogram. This filtration process involves excluding environmental surveillance, eliminating duplicate isolates to include only the first per patient, ensuring statistical significance with at least 30 isolates per species, and reporting only susceptible results. This output defines our local empiric therapy. A robust policy rests on 3 pillars of care: prophylactic therapy to prevent infections, such as surgical prophylaxis within 120 minutes of incision; empiric therapy, which is broad spectrum and driven by local antibiograms; and targeted therapy, which uses narrow spectrum agents for bacteriologically confirmed infections once cultures are available. Prescription logic follows 4 questions. First, is the patient actually infectious? This determines necessary tissue penetration, such as using ceftriaxone for meningitis. Third, which antibiotic is appropriate based on local resistance? We start broad and then rapidly de-escalate. Finally, what is the optimal dose based on host factors like age and renal function? We stratify patients into 4 types. Type 1, low-risk patients have few comorbidities and minimal MDR risk. Type 3, high risk, includes elderly patients hospitalized for over 5 days, requiring broad-spectrum Group 2 carbapenems. Type 4, critical risk, involves severely immunodeficient or ICU patients with a stay of over 3 days, necessitating coverage for pan-drug-resistant bacteria or invasive fungi. To optimize patient outcomes, a targeted antibiotic policy must be paired with infection care bundles. A precise policy will fail if source control and physical infection prevention, targeting CAUTI, CLABSI, VAP, and SSI, are ignored. For CAUTI, we prioritize silicone catheters and daily assessment, avoiding treatment for asymptomatic bacteriuria unless the patient is pregnant or undergoing urologic surgery. For CLABSI, we prefer subclavian vein access, utilize 0.5% chlorhexidine prep, and ensure the removal of short-term CVCs if Staphylococcus aureus or Candida are detected. Preventing SSI requires preoperative CHG baths, mupirocin decolonization, and strict glucose control. Surgical prophylaxis must be redosed if the procedure exceeds 2 drug half-lives. For VAP, we focus on head elevation and oral care, basing empiric therapy on whether the onset is early, under 4 days, or late, 5 days or more. AMS actions are divided into front-end and back-end. Front-end actions include formulary restrictions, pre-authorization for drugs like colistin, and automated order sets. Back-end actions involve prospective audit and feedback, forced de-escalation, dose optimization, and timely IV to oral conversion to expedite discharge. We track success through 3 indicator types. Structural indicators check for active MDTs and updated antibiograms. Process indicators measure guideline adherence and days of therapy. Clinical and outcome indicators monitor mortality rates, C. difficile reduction, and the standardized infection ratio, aiming for a target under 1.0. We must move from manual retrospective surveillance to automated real-time tracking. This loop integrates lab analytics and IT middleware to send actionable alerts instantly to clinicians on the floor, allowing the AMS committee to update policies dynamically as resistance patterns shift. In conclusion, antimicrobial stewardship is the aspirin of the 21st century, a fundamental requirement for safe care. We must empower the HICC structure, trust our local antibiograms, and strictly enforce care bundles to protect our patients and the future of medicine.